Good afternoon, everyone. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire. And today I'm joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
And joined by Lieutenant Antonio Romero.
Chief.
Good to see you again, brother.
Always a pleasure.
All right, so I appreciate you coming out. Today you're going to talk about an interesting case of an aortic dissection that you ran on while assigned over at Medic 12. So it sounds like the call initially came in with yourself and Engine 12 going to a 10 Delta 3. And initially came in with a 66-year-old male complaining of chest pain. Pretty regular call, especially for a busy truck like Medic and Engine 12. Let me know what you're thinking about when you're en route to a call for a 10 Delta.
So as we're going en route for the 10 Delta, you're thinking chest pain. And I'm like, okay, well, what kind of temperature do we have outside? How's the weather? What I'm going to think about everything. And as we arrived on scene, the guy, he walked outside and met us, and he seemed real calm, cool, and collected, and I was like, okay, we'll just check this out. As I'm thinking while I'm en route, we're thinking, cardiac protocol. I'm thinking aspirin. I want, IVs. How far? Let's make sure we get that EKG within the first 5 minutes. Just make sure everything is taken care of. We cover our bases,
And you talked about the temperature, so this was summertime, so we had a hot summer, over 100 degrees. You get there, he's waiting for you outside. You guys are able to get him back inside, get him into the AC to talk to him a little bit better. But it's a great thought about thinking about the temperature and just the environment that they're in and what they would be doing prior to calling 911. So what did he tell you as soon as you started making that first initial assessment and contact?
So right out the gate, he met us outside, like I said earlier, and he was like, hey, come on in. He seemed real calm, cool, and collective, super diaphoretic. And I was like, wow, it's real hot out here. Let me rule that out, And so I was like, sir, let's go back inside, where it's nice and air conditioned. And he goes, okay, sounds good. We walked back inside, and he just sat there, and his color was kind of what was telling me something. He looked real ashen. He looked, real pale. The diaphoresis, I wanted to make sure that, rule out because of the temperature and, so let's go in a cool environment. And I was like, let me feel your hands. And his hands were real cold and clammy. And I was like, something was telling me, especially with a 10 Charlie, like, this is screaming cardiac. This is what it's telling me. It's screaming cardiac.
And that's fantastic. And we talk about this regularly too, right? So not only vital signs, but your patient assessment. And honestly, just touching a patient sometimes helps paint the picture as to what's going on. So I appreciate you saying that. And everybody who's visited their primary care physician, if they have a good one, right, a lot of times they'll do that. They'll check your skin temp and kind of just touch, because it gives you a lot of information that maybe the patient might not be able to elicit to you. So that's a fantastic job. So what did he tell you? What was his complaints? Did he say, I have chest pain right now? Did he say he was...
So he didn't really say that. Like, it wasn't like the classic textbook chest discomfort, crushing chest pain, 10 out of 10. No, he was like, I just feel like I have heartburn. And like I said, he was real calm about it. And he's like, I feel like I have heartburn. I've been eating Tums like they're no tomorrow, And I was like, okay, a lot of Tums. And I was like, do you have a cardiac history? And he goes, yes, I have. I'm diagnosed with AFib. I was like, okay. And, are you experiencing any other pain? And he goes, yeah, I have a little bit of back pain, but I have chronic issues with back pain. I was like, okay. And I had my partner check his pulse, and, I'll get to this later, but he checked with one hand, just one side, and apparently that was the good side. And, he's like, hey, it's regularly irregular. And I was like, well, he has AFib. That makes sense. And I was like, well, sir, do you have are you on any kind of blood thinners? And he goes, yes, I'm on I think Coumadin. I was like, okay. And then after we checked for the blood thinners, I was like, well, let's get this EKG real quick. Let's finish up our vitals. So we finished up the EKG. It, just proved what he told me. He has AFib. Nothing really stood out to me. His vitals were slightly elevated, like blood pressure of 151 over 79, SpO2 was 97, things are somewhat like slightly elevated, but nothing, that really relates with his presentation. And so as we were doing that, I was like, well, you know what? I don't see anything. I just don't like his color. I don't like the way he's presenting to me. Let me just go down this cardiac protocol. So I started going down the cardiac protocol, and we gave him some aspirin. And I was like, sir, you ever taken aspirin? And I was even thinking, like, well, he's already taking blood thinners. Aspirin is, minuscule in comparison. So we gave him the blood thinner, or gave him the aspirin, and no relief after reassessment. And I was like, you know what? Let's go en route to the hospital. Let's get you transported. I don't like what I see. I don't know what's going on, but I think it's a good idea. And he was even saying, I don't really want to go if I don't have to. I don't want to wait in those long lines. And I was like, well, something's just telling me, this is my personal opinion, I think we should go.
And that's pretty much all we can do at that point, right? Is their presentation, something doesn't look right. So what they're telling us doesn't really match the way they look. They look worse than they're telling us, right? I guess that's the best way to put it. Exactly. And it can be so nebulous as to what's going on. So Doc, from your perspective, throw out some of the things that you think of when somebody's telling you, hey, I have chest pain or just general discomfort in this area.
Yeah, that's an excellent question. I think we see so much acute coronary syndrome or folks with risk factors for cardiac disease, thinking STEMI or ischemic heart disease. But there's other things that can cause chest pain as well. So some of the more frequent ones, pneumonia can be very painful. PE causes pain, when you take an inspiration. Tension pneumothorax is painful. That's usually in the setting of trauma. But there's a couple more that we don't see very often. One would be a pericardial effusion, fluid around the heart. Esophageal rupture can go with like really violent vomiting, or an aortic dissection where actually the fibers of the major vessels in the heart are actually ripping and tearing and can be a severe emergency.
So in this case here, we've talked about the AFib. He mentioned a history of CHF, which everything kind of lined up. He wasn't having that crushing chest pain, but it's kind of a dull, aching pain that he'd had for a while. So we are telling him it's probably best that you be seen, right? So now we're in the back of the ambulance. We're going to do a secondary assessment, a little more thorough. Walk us through that and tell us what you found.
So as we walked him to the gurney, I also I ruled out the PE. I wanted to see how he was going to walk and if he was going to, lose his breath after a couple steps, and he didn't. And I was like, okay, so, that's not a definite way, but, it's some way with the information that I have on this gentleman. And we got him in the back of the ambulance, and I was talking to AES, and I told him I don't like his presentation, but his numbers are all kind of, looking normal. I don't want to see this guy go, I don't want to miss something. And I was like, do you guys need anything? And they're like, no, we'll get an IV en route, and we'll take a look. So the call was almost over. We got back to the truck. My partner was already putting a seatbelt on, and I had that feeling. I was like, let me go back one more time. And I went to the back of the ambulance, and I was like, sir, can I check both of your pulses? And he gave me his arms, and I checked, and one of them was just weak. It was like a whoosh, whoosh, and the other one was bounding. Boof, 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 boof. And I was like, oh my gosh. I was like, hey, let's get bilateral blood pressures. And so, sure enough, one of them, the good arm, we just happened to check, what read the same, 151/79. The other one, I think, was like, I don't even know, like 80/PELP or something like that. We couldn't get anything. And I was like, son of a gun. And I was like, sir, is there, like, dude, when you have that chest pain, does it kind of radiate towards your back? I'm starting to think textbook. I just got out of the academy, and I was teaching the EMT basic students, just the classic signs of these aortic aneurysms. And he goes, yeah, how did you know? And I was like, well, that would have been a little bit nicer to tell me sooner. But, I wanted to rule out that, he said that he had that chronic back pain. On top of that, I was like, sir, do you normally have this distended belly? And he was like, come to think of it, that's kind of new. And I was like, okay, well, I'm going to just push down your stomach real quick. I want to feel something. And I just added just a light, just a little bit of pressure. And Sure enough, you just feel this poof, poof, and you feel it. And it's just bounding on his stomach. And I look at the other paramedic, and I'm like, I think this guy has a AAA. And I look at him, and I was like, sir, do you have any history of having any AAAs? And he goes, well, yeah, but that was more than 10 years ago. And I was like, well, that would have been nice to know when I asked you about past medical history, but at least we figured it out. And I asked the AS medic, and I was like, do you need a writer? And he goes, I think we're going to be okay. Just keep your radio on just in case. And I was like, okay. And I was like, I just want to let you guys know, I did give him aspirin. I know I went down the cardiac protocol, but I'm glad that we caught this. Things that I'm going to do from now on, is whenever I ask, how is the pulse? Because I like to get a manual pulse anyway. I'm going to check it bilaterally every time now. And, they made their way to UNMH, where he was actually treated for his AAA.
Unbelievable. It's always frustrating, but it happens so regularly where you have an assessment, you've done 15, 20 minutes with a patient, and then like the key information gets either told to the hospital or it gets told to the 5-5 crew when they arrive, and that's always frustrating, but it doesn't matter. As long as somebody knows about it, I think that's the key. So that's unbelievable. So not the normal presentation that we would see from a potential dissecting AAA. Doc, talk to us about what we would typically see as the normal signs.
So I always love to say patients don't read the textbook, and I really love the fact that you just listened to your gut here. You knew that something was wrong. You were even back in the truck, and you just didn't quite feel satisfied, and you went, if you hadn't done that double check, who knows? So I'm glad you listened to that inner voice that was telling you that something was wrong. With these folks, what the textbook would say is exactly what you said. There may be a different character to the different radial pulses, and then chest pain that radiates to the back. It usually comes on pretty suddenly is the description, and sometimes is associated with neurological deficits too. So this is a ripping or a tearing in the vessel walls. And if you remember, the aorta has three pretty strong, is the biggest artery in the body, so three really strong layers to it. And it's where the blood, there's a small tear, and the blood is actually pushing its way between the layers and dissecting its way down. And as a result of that, one of the vessels off of the aorta may have less blood flow, so that's the decreased pulse that you're feeling. But also importantly, along some of those vessels are the nerve bundles, and so you can see stroke-like symptoms or sometimes paresthesias or any kind of neurological deficit that you can imagine. If I ever have chest pain plus neuro, I always start to think a little bit more about dissection. And that may have been the case here. And then with the back pain, too, because it can radiate to the back. This gentleman did have the vascular disease, and so his went all the way down to his thoracic cavity where you could feel the pulsatile mass. And it's a good thing you didn't push too hard on those, because if that vessel wall is too friable, it can rupture, which is the thing we're trying to avoid. But it's really interesting when you do feel it, because you're like, oh, man. And then you go a little faster. But the goal with these folks is to keep their blood pressure low, actually, because you don't want to put any more pressure than you have to on that vessel wall. And so treating their pain actually goes a really long way, because it's a painful process as it's dissecting down, and there's all that pressure on the vessel wall. And so the aspirin here, I don't know that it would have made anything better or worse, and it is in our guideline. And he's already on the thinners, like you mentioned, too. So, but treating pain to help decrease that blood pressure and the pressure on that vessel wall, just doing everything we can to decrease the likelihood of it rupturing before he gets to a surgeon.
Mm-hmm.
Absolutely.
Incredible. This is an incredible case, and I think we talked about the patients don't read the textbook, but obviously your time here in the training division, prior to being promoted out to the field, you did read those textbooks, and it's playing out, when you actually encounter these patients, and that's all we can ask for. So I think the whole goal, we've talked about it with these case studies, is sharing this information with field crews. So if you had to package it up and teach the field crews of exactly what you did on this call well, what you did differently, or what you want to teach them for the next time, what would that be?
I think the biggest thing, just to reiterate, like I said earlier, is, when we're doing our primary assessment, follow your gut. These presentations. The other one that I will start doing from, here on out is just having my partner check pulses bilaterally. Just right out the gate, it doesn't take much time, and it's just a simple thing just to rule another, major incident out.
It's incredible. Great job.
Yeah, it's
Great job.
fantastic. It's an
Fantastic
excellent
case.
pickup.
Thank you.
And obviously there was repair at the hospital side, so good outcomes for the patient.
I think I probably can't tell you how important it was that you had this suggestion for them to tip them off right away, because this is truly an emergency. And sometimes even in the hospital, we don't think about it until later. And the fact that you kind of gave them the hint that you had checked those blood pressures and pulses to get that imaging early, get the surgeon on board early, made a big difference for this patient. So
That's great. Thank you, Doc.
yeah.
Saved life. Well, I appreciate you taking the time to come and talk to us today. If anybody else has some interesting cases they would like to share, go to SharePoint. We have a submission tab that you can submit your case, or reach out to the 7-8 or any one of us. And until then, we'll see you next time. Thanks.
Thank you.